I welcome you all to this second ENT lecture. The topic for today is congenital anomalies of upper digestive tract. So, since it is on congenital anomalies, most of our discussion today would be centered on the embryological aspect. So before I go on to the topic, I would like to introduce two terms to you. One is congenital and the other is developmental. They appear to be similar, but there is a difference between the two terms. Developmental anomalies strictly means those anomalies which have an embryological origin. Whereas the congenital anomalies have a much wider spectrum, developmental anomalies are also included in it. Apart from those various anomalies which happen due to an adverse perinatal event may also be labeled as congenital anomalies. They may not be of genetic origin. So with that, we go on to today's topic. So we will be covering the embryology. On the way, I will be discussing about the various anomalies which take place owing to developmental defects. So we will cover the initial embryology, followed by the embryology of the specific organs like the oral cavity, pharynx, esophagus, larynx, and the embryology of the certain associated structures. So first of all, the embryology of gut. So we start at this place, the development of the foregut. The precursor is the yolk sac, which is something like this. It has a relation with the amniotic sac and the notochord. So here you have the amniotic cavity. And here you have the yolk sac. In between the two, you have the notochord here. So this amniotic sac and the yolk sac, they remodel extensively to ultimately form the foregut, midgut, and hindgut, which at the midgut they communicate with the yolk sac. So all around this structure is surrounded by the amniotic sac. In this manner. The notochord here leads to the formation of the neural crest, which forms the brain. So here you have anterior, here you have posterior. So here you will have the foregut, the midgut, and the hindgut. The foregut is in the anterior most aspect, the cranial most aspect of the foregut is in contact with the amniotic sac. This point of contact here is known as the buccopharyngeal membrane. Now, this foregut is our area of interest. Foregut itself leads to the formation of a lot of structures, right from the oral cavity and face, right up to the duodenum. So we can infer that the area of our interest will develop only from the most cranial aspects of the foregut. With this knowledge, we move on to the development of pharyngeal arches. Okay, so now what foregut we have seen here, you imagine it as one long tubular structure. Okay, so the tubular structure will be seen something like this, with an outer ectodermal and an inner endodermal layer. So here you have the foregut. It is in communication with the stomatodium. The opening of the amniotic sac, the point of contact of the amniotic sac with the foregut is known as the stomatodium. So here you have the stomatodium, here you have the foregut, and here you have the buccopharyngeal membrane. So it is this buccopharyngeal membrane which disappears in some time, and the structure then starts to look something like this. Okay, so here, sorry, I'm so sorry. This buccopharyngeal membrane I've created again. This has to go. So it will look like this. So thereafter, this pharyngeal arches start to now develop. Now, all this development that we are talking will happen in the lateral wall of the foregut and the stomatodium. So, in the lateral wall of the stomatodium and the foregut, some thickenings appear. 6 thickenings appear, out of which 1 disappears. So only 5 are left. So we have 1, 2, 3, 4, and 5. Similarly here, 1, 2, 3, 4, and 5. The endoderm will look like this. Okay, so these thickenings are the arches. This is the first arch, this is the second arch, third, fourth, and sixth. Okay, so now slowly, once these pharyngeal arches have started to develop in the lateral wall, they then start to grow ventrally, like supposing these are the two pharyngeal arches, they start to grow ventrally and medially towards each other to meet in the midline. So what happens that uh, bar-like structures appear. Imagine a tube with bars on it on the ventral aspect only. Okay, so these are the pharyngeal arches which have now uh, developed 1 to 6. Okay, minus the fifth one. Okay, so now once these pharyngeal arches have appeared. Now in between two pharyngeal arches, you can see indentations. One indentation here is in the ectoderm, these indentations. And the other one here is in the endoderm. So what are these? Now, the indentations in the ectoderm are known as the ectodermal clefts. Whereas the one in the endoderm is endodermal cleft or pharyngeal pouch. So we have these three structures with us: pharyngeal arch, ectodermal cleft, endodermal cleft, or pharyngeal pouch. So whatever structures of our interest we are going to discuss about today will develop from one of these structures only. Okay, with this in mind, we go on to the next topic, the development of each pharyngeal arch, the structures derived from each arch. So first, the first pharyngeal arch. The first arch is also called the mandibular arch. Okay, here I would like to stop for a while and just discuss these arches in the components of these arches. Each of these arch will have a skeletal component. Then nerve, then skeleton, artery. So the skeletal component may be cartilage or mesenchyme. We won't be talking much about the artery since it is not of much relevance to what we are discussing today. In future, in one of the topics, we might discuss about the artery as well. So with that, we go on to the first pharyngeal arch or the mandibular arch. Now, it has a skeletal component. The skeletal component is the Meckel's cartilage. Now, this Meckel's cartilage, it has a variable fate. In the um, um, in the ear, it forms the incus and the malleus. Incus and the malleus. And then it forms the sphenomandibular ligament. The remaining portion disappears and is no longer important. Then the mesenchyme, the next skeletal element is the mesenchyme. This forms the mandible. Okay. This forms the mandible, bones of face, nose, so on and so forth. And then you have the nerve. This first arch has two nerves. One is the pre-traumatic nerve, which is the chorda tympani, which is a branch of the facial nerve. Then you have the post-traumatic nerve, which is which are in fact two maxillary and mandibular branches of the fifth nerve. Okay, and the associated muscles will be there. Which muscles are derived from the mandibular arch? Muscles of mastication. So you have the temporalis, the masseter, medial and lateral pterygoids, then you have the anterior heligastric. Then, since the malleus is derived from the first arch, its muscle also comes from the first arch, hence the tensor tympani. Okay, and so these are the most important ones. Then we go on over to the second arch. Second arch is known as the hyoid arch. It has a skeletal element is known as the Richards cartilage. This forms the stapes. Now, since the stapes is forming, it will also form the stapedius. It will also innervate the stapedius. Okay. So stapes. Then you have the styloid process or the styloid complex. Then you have the stylohyoid ligament. Then you have the lesser horn of the hyoid. And finally, you have the upper superior body of the hyoid. Nerve supply is the facial. So, since the facial nerve is the nerve supply, The various muscles which are supplied by it will be the muscles of facial expression. So you have the oxynator, um, you have the frontalis, oculo, orbicularis oculi, orbicularis oris, nerve to stapedius, posterior heligastric. So these are some of the muscles which will be supplied by the hyoid, by the second arch. Next, we go on to the third arch. Third arch does not have a name. Its cartilage is also unnamed. However, its nerve is the glossopharyngeal nerve. And its cartilage forms the greater horn of hyoid and the lower body of the hyoid. Okay, now the fourth and sixth arches. Okay, these are considered together because their separate derivatives are still not clear. Hence, they are considered together. The nerve of the fourth arch is the superior laryngeal nerve. Whereas the nerve of the sixth arch is the recurrent laryngeal nerve. Now, from the nerve supply itself, you can make out what muscles would be supplied and what would be formed. So, these form the laryngeal cartilages. The various muscles supplied by it include the intrinsic muscles of larynx, and the muscles of pharynx. Now, the third arch nerve, the glossopharyngeal nerve, supplies only the stylopharyngeus muscle. It is predominantly a sensory nerve. It hardly has any motor component. So, the gag reflex in the oropharynx is supplied by the glossopharyngeal nerve, which again indicates its origin. So now we have completed the various arches. So now we come on to the each organ separately. First of all, the face. Now, the face and nose, we will not discuss in too much of detail because it is a topic for another lecture. I will only be touching upon it because of the clinical significance of certain anomalies. Face, nose, mandible, oral cavity. Okay, now here you have the mandibular arch This separates into two: maxillary process and the mandibular process. Okay, so the maxillary process forms the upper part of the face. This includes the nose, the orbit, the zygomatic arch, some parts of the temporal bone, hard palate, upper alveoli, upper lips, and the lower and the mandibular process forms the mandible, floor of mouth, and tongue, and the lower part of the face. So, so this is how it works. Now, the oral cavity. We come on to this next part of the topic. The oral cavity has, as we had discussed with the pharyngeal arches, and with the development of the pharyngeal arches, we demarcated the ectoderm and the endoderm. Now, oral cavity is the only part of the entire foreguard where you have components both from the ectoderm as well as the endoderm. So, the parts from the ectoderm include the lips, both upper lip and lower lip, the alveoli, upper as well as lower, the teeth. Okay. However, the floor of mouth and tongue, they are derived from the endoderm. The hard palate is also developed from the ectoderm, not endoderm. Okay, so this is how the oral cavity starts to develop. Now, coming on to the development of tongue. Now, again, earlier we had discussed about the pharyngeal arches. Here you have the pharyngeal arches. So, we are going to now talk about what derives from which pharyngeal arch in brief. So, the first pharyngeal arch develops in the median part, develops two swellings like this. These are the lingual swellings. Let me show it in a bigger perspective. Lingual swellings. Okay. Behind this is in the median part is a small swelling known as the tuberculum impar. Behind the tuberculum impar is a small depression known as the foramen cecum. Okay, so this is about the first arch. Now, in the third and the fourth arches, second, third, and the fourth arches, another swelling emerges. This is known as the hypobranchial eminence. So, lingual swelling, then you have the tuberculum impar, and here you have the foramen cecum. First, we'll talk about these contributions of the first arch. Now, what happens to them? The three swellings will merge with each other. The lingual swellings merge in the midline in this manner, and posteriorly they merge with the tuberculum impar. The foramen cecum lies posterior to it. Just behind it, the hypobranchial eminence develops, and it then divides into two: a cranial component and a caudal component. The cranial component develops from the third arch, whereas the caudal one develops from the fourth arch. So later on, next step, what happens that these swellings, they fuse with each other. First, the tuberculum impar and the and the lingual swellings fuse with each other like this to form the anterior 2/3 of the tongue. Right? Now, then the cranial component of the hypobranchial eminence will also fuse with this to form the posterior 1/3 of the tongue. The caudal component of the hypobranchial eminence forms the posterior most part of the tongue and also the epiglottis. So now, supposing this fusion does not occur, what would happen? You would have a hyphaid tongue. So one anomaly is right here, hyphaid tongue. Next important thing is that the nerve supply. Now the nerve supply of the first branchial arches, mandibular nerve, and the chorda tympani. So the taste sensation to the anterior 2/3 of tongue is from the chorda tympani and the lingual branch of the mandibular nerve. The nerve of the third arch is the glossopharyngeal nerve. Hence, the sensation in the posterior 1/3 of tongue is derived from the glossopharyngeal nerve. Epiglottis is supplied by the superior pharyngeal nerve. Now, during the development of the tongue, it evolves from the mandibular process of the mandibular arch. During development, it separates out as a projection from the floor of the mouth, and thereby the tongue assumes the shape it has. If this separation remains incomplete, what would happen? Ankyloglossia. So you have ankyloglossia or tongue tie. The other disorder we talked about was bifid tongue. Next, if the tongue remains very small, it does not, its growth is impaired at a certain stage. It would lead to microglossia or aglossia also. If it is too large, macroglossia. Fine. So with that, the development of tongue is complete, except for one structure, which is the foramen cecum. So with this, we come on to the what happens to the foramen cecum. Now here you have the your surface of the tongue, and here you have the foramen cecum, which is a depression actually. Now this depression elongates, becomes deeper, and it elongates in this manner. This is the thyroglossal duct. This grows further to reach the hyoid bone. Here you would have the hyoid bone, and it goes beyond the hyoid, either posterior or anterior or through the hyoid bone. Thereafter, it develops two herds. It becomes bifid. These two herds, they later on form the thyroid gland. Now, during this process, what are the various possibilities which can happen? Now, in a normal human being, this thyroglossal duct, after formation of the thyroid glands, it is supposed to degenerate. However, in many cases, it persists. Now, its persistence itself should not create any problems. However, if it forms a cyst or a fistula, in that case, it becomes a problem. It is known as the thyroglossal cyst or a thyroglossal fistula. Next, what can happen? Since the thyroglossal duct leads to formation of the thyroid gland, this thyroid gland can be present right within the tissues of the tongue. So it can lead to formation of a lingual thyroid. It can lead to some foci of thyroid tissue anywhere in the thyroglossal duct. So it can be in the tongue, it can be anywhere in the thyroglossal duct, it can be above the hyoid, in which case it will be suprahyoid thyroid. It can be below the hyoid, in which it will be infrahyoid thyroid. It can even go into the thorax. In that case, it will be known as thoracic thyroid. or rather intrathoracic thyroid. Okay. Now we go on further. We go on to the development of the pharynx and the esophagus. Now, here again, we have to see one more concept. We have so far discussed about the derivatives of the pharyngeal arches, whatever structures we have seen so far, they have developed from the pharyngeal arches. Now, in the initial diagram of these pharyngeal arches, we have seen about the ectodermal cleft and the endodermal cleft or the pharyngeal pouches. What happens to them? Now here, first of all, here in the first pouch, supposing here you have the first pouch and the second pouch. Okay, first pouch, second pouch, like this. These are the two structures. Now the ectoderm of the first pouch will grow inwards and the ectoderm of the second pouch will grow outwards into the mesenchyme. Okay. The indentation of the first arch, of the first ectodermal pouch, will lead to formation of the external auditory canal. Let me just give a more magnified view. So this will grow inwards to form the external auditory canal and also externally the pinna, whereas the first pharyngeal pouch will grow into the mesenchyme as the tubotympanic recess. Tubotympanic recess. Okay, this deepens further to first form the eustachian tube and thereafter forms the middle ear. So this middle ear then comes in contact with the tympanic, with the external auditory canal at the tympanic membrane. We are not talking much about the ear. Okay, some component of this first pharyngeal of this eustachian tube is also from the second pharyngeal arch. Now, why are we talking about the ear all of a sudden? Because of the eustachian tube. Where does the eustachian tube open? Apart from one end opens in the middle ear, where does the other end open? In the nasopharynx, lateral wall of nasopharynx. So means this part of the foregut near the first pharyngeal pouch corresponds approximately to the region of the nasopharynx. Fine. Now the second ectodermal pouch, or second pharyngeal pouch. it forms the palatine tonsil here. The lateral aspect of the first pharyngeal pouch forms the tonsil. The tonsil lies in the oropharynx. Hence, the region of the second pharyngeal pouch corresponds approximately to the region of the oropharynx. Hence, we come to know that this region, the cranial most part of the foregut, is the one that leads to formation of the pharynx and the oral cavity also, as we have seen. Now, just for completion's sake, the third and fourth pharyngeal pouches lead to formation of the parathyroid glands, and the fourth ectodermal pouch also forms the lateral lobe of the thyroid gland, which goes and fuses with the thyroid lobes formed by the thyroglossal duct. So we had seen about the thyroglossal. So here you will see the third one will form the parathyroid. Here also fourth one will form the parathyroid, as well as the lateral lobe of the thyroid. Okay, so this lateral lobe of thyroid fuses with the thyroid gland formed by the thyroglossal duct. This lateral lobe of the thyroid is the one that is responsible for findings of ectopic thyroid in a lateral position in the neck. Fine. Now, one last thing that is left. This second pouch, what happens to it? Sorry. This overgrows the remaining. This overgrows the remaining ectodermal pouches. Here you have the formation of the branchial cyst. If this cyst, normally this cyst is filled up with the mesenchymal tissue and hence is obliterated. But if it continues to persist, it leads to the formation of branchial cyst. And if it opens out into the skin, it is the branchial fistula. Okay, so now we have covered the branchial cyst and the branchial fistula as well. Now we will now go on to the esophagus. Okay, now to explain about the esophagus, we have to understand one thing, that what you are seeing here is the component of the pharyngeal arches. Further caudal to all these structures, if we go further here, you will reach the stomach. In an embryo, there is no neck. As the neck starts to form, the esophagus starts to emerge. The formation of esophagus is also aided by the caudal migration of the diaphragm and formation of the pleural cavities also. So this is about the esophagus. Now there are certain anomalies associated with the esophagus and the pharynx which might be important. If the some portion of the esophagus might be absent, which is atresia. Or it may be formed properly, but some portion may not have annulated adequately. Again, it is atresia. The third form is stenosis. Formation is there, but it is stenosed. Another anomaly is the tracheoesophageal fistula, which we will discuss when we are discussing the embryology of the pharynx and the airway. So with that, we go on to formation of the pharynx. Okay, so now we again have to go back to that same structure, redraw that same structure about the pharyngeal arches. I won't make it in too much of detail now. Okay, so here you had the first arch, second arch, third arch, fourth arch. Here you had the hypobranchial eminence. Okay. Behind the sixth arch, you have a small groove emerging, a longitudinal groove emerging. This groove is called the tracheal groove. This is where the airway, the larynx, starts to segregate from the pharynx. This tracheal groove in an adult is represented by the pharyngeal inlet. Because until the laryngeal inlet, there is only one aerodigested tract. Now, the pharynx esophagus is extending in this manner from caudal to cranial. So this tracheal groove, it starts to deepen and then it starts to grow parallel to the esophagus, again in a caudal direction. So how does it actually grow? Now, supposing I take a cross section of the pharynx. Now, pharynx looks like this. If you take a cross section, it looks like this. Longitudinally, it will look like this. Okay. Then this esophagus, it starts to develop a outpouching. First of all, it's not analyzed, but later on it becomes analyzed. In this manner. it elongates to form the larynx, sorry, no, it elongates to form the pharynx. Here you have the esophagus. Now, further on, this larynx will become bifid. The larynx becomes bifid like this. This is the tracheal bud. Now, above this bifurcation, you have the trachea. Below it is the tracheal bud, which leads to formation of the bronchi, bronchioles, and hereafter leads to the formation of the lungs. So this is how the lungs develop. Now we come on to the final part of our lecture today, which is the developmental anomaly of the larynx. Again, like esophagus, the larynx may be complete, it may be atretic in some part, or it may be stenotic, as in subglottic stenosis, or it may have a tracheoesophageal fistula. Now we will focus on the tracheoesophageal fistula. Here we have the larynx interior, the trachea anteriorly, and here posteriorly we have the esophagus. Now, anywhere between the two, there would be various kinds of communications. One would be an obvious communication, both-way communication, or there might be one limb of either of the two missing. So here the trachea opens out into the esophagus straight away, or it might be something else like this. This portion will be atretic. It would be something like this, otherwise. So these are the various means in which the tracheoesophageal fistula might occur. So with that, I conclude my talk for today. Thank you so much.